So now, everybody, I want to pass this off to Nafisah. Nafisah is at Bebashi, and Nafisah will lead us with the healthcare updates and advocacy. Take it away, Nafisah.
Hi, everyone. So today I'm going to introduce our presenters. First up, we have Dr. Karam Mounzer, who is the Chief Scientific Officer at Philadelphia Fight and Clinical Professor of Medicine at the Perelman School of Medicine at the University of Pennsylvania. He is board certified in infectious disease and internal medicine and has over 30 years of experience in the medical field. Second, we have Michelle Troxell, who is the co-chair of Positive Women's Network, PA Chapter, a founding member of PA HIV Justice Network, a core member of Vote Positive PA, and a member of the PA HIV Planning Group. Michelle is the founder and CEO of Awake, Alive, Abundant Coaching, guiding clients to unleash their full potential and live authentically as the divine creators they are on the earth to be. We also have Heshie Zinman, who has served on the National Steering Committee for the Reunion Project for the last 2 years. He also serves on the Pennsylvania Governor's Commission on LGBTQ Affairs and the Philadelphia Mayor's Commission on Aging. He is a co-founder of the LGBT Elder Initiative and volunteers on the Elder Initiative's HIV and Aging Community Advisory Committee. So welcome to our presenters, and we'll have question and answers after they present, and you can put your questions in the chat box.
Hello, everyone. My name is Karam Mounzer. I'm the Chief Scientific Officer at Philadelphia Fight. I'm a clinical professor of medicine at the Perelman School of Medicine at the University of Pennsylvania. I would like to thank the organizers for inviting me today to give you an overview on the new trends in HIV-1 treatment geared towards long-term survivors with a special focus on long-acting agents. These are my disclosures. In today's talk, I would like to discuss two treatment strategies involving long-term survivors. The first one is treatment optimization targeting suppressed patients. And here I will walk you through 3 scenarios highlighting the role of 3 drug-based single tablet regimen, 2 drug-based single tablet regimen, and long-acting injectables in the management of our long-term survivors. And the second strategy is revolving around treatment modification, targeting highly treatment experienced patients failing with a multi-drug resistant virus. And here, I would like to discuss with you how to build a salvage regimen centered around a fully active agents that belong to a new class. And finally, I would like to give you a quick introduction to the long-acting agents that are in the pipelines. But before we go ahead and start, it's very important to acknowledge the many challenges that our long-term survivors have to confront and overcome throughout their journey with HIV. As you know, there are many risk factors that tend to cluster among people living with HIV, and they are taught primarily by their HIV infection itself, obviously aging, smoking, substance use, chronic viral infections such as Hep C, Hep B, and HPV, antiretroviral treatment toxicity itself, obesity, lack of exercise, unhealthy diet, stress, depression, and genetics. The interplay of all these factors will drive chronic inflammation and fibrosis, dyslipidemia, insulin resistance, decreased physical functioning, which lead over time to end organ disease and damage. Hence, the higher incidence of cardiovascular disease, cancers, neurologic impairment, bone disease, kidney disease, liver disease, metabolic disorders, and frailty among our long-term survivors. Effective antiretroviral therapy is the most important intervention to slow down that trend and to enhance the long-term health of our patients. Obviously, it has to be coupled with prevention and treatment of underlying comorbidities and healthy lifestyles. So what is effective antiretroviral therapy? It's the combination of antiretroviral drugs that enables us to achieve a full and sustained viral suppression. So what are the characteristics of an effective antiretroviral therapy? In other words, what are the characteristics of an ideal regimen? It's a regimen that is simple, convenient, well-tolerated, forgiving, It's a regimen that has few to no toxicities, and it's a regimen that has no drug-drug interaction. And most importantly, it's a regimen that has no negative impact on the underlying medical conditions that the patients may have, which are many. This slide outlines and highlights the most important accomplishments that we've achieved over the last 30 years in our quest to develop that ideal regimen. As you can see, HIV treatment has been an evolving paradigm, going from multi-tablet regimen several times a day to a single tablet regimen that's NNRTI based, to a single tablet regimen that is integrase based, and now to a 2-drug single tablet regimen, integrase based. And finally, we're entering a new era of long-acting injectables, Cabotegravir, which was recently approved, which is a combination of Cabotegravir and Rilpivirine long-acting. In today's talk, I would like to focus primarily on those drugs that have been approved over the last 4 years and how they shaped our treatment trends and our guidelines. So you can see highlighted in yellow, these are fixed dose combination, single tablet regimens. Some of them are 3-drug based, Cabotegravir, FTC-TAF, Biktarvy, darunavir, Cabotegravir, FTC-TAF, Zintuza, Doravirine, TDF-3TC, Delstrigo, or 2-drug based single tablet regimens like dolutegravir, 3TC, Dovato. Also in red, you see the newly approved long-acting injectables, Cabotegravir and Rilpivirine. And also I added 2 new drugs from 2 new classes, Ibalizumab and Fostemsavir, that are used in combination with optimized background regimen to treat highly treatment experienced patients failing with multi-drug resistant virus. And I will focus specifically on Fostemsavir later on. So what are the treatment strategies that are implemented in long-term survivor, and how have they been affected or impacted by the advent of these newly fixed dose combinations? To answer this question, it's very important to acknowledge the fact that long-term survivors are not all created equal. In fact, you have long-term survivors who are treatment experienced with no documented resistance and who are suppressed. These are the minorities among long-term survivors. And the question is, when we see them in our practice, we have to pose the question, are they on the best regimen they can be on, or is there room for treatment optimization? I.e., can we put them on a simpler regimen, more convenient, better tolerated, less toxic, with few to no drug-drug interactions? And you will see in these instances that there's a room to simplifying these patients' regimen and switching them to a single tablet 3-drug or 2-drug regimen. And now we have a new option to offer them, which is the long-acting injectables, which I will be discussing in a second. Now, the other type of long-term survivors are those who are treatment experienced, but who have documented resistance. And those patients are divided into 2 groups, those who are suppressed. And again, when we see these patients, it's important to pose the question whether or not they are on the best regimen they can be on, and is there room for treatment optimization? And here I can tell you that there's sometimes ways to simplify their regimens to a 3-drug or a 3-drug plus another active agents, which makes it 2 total pills a day. And then you have those who are treatment experienced with resistance and who are viremic, failing with a multi-drug resistance virus. And here we have to modify the regimens altogether. And I will be discussing with you a very effective all-oral regimen that's centered around a new drug from a new class. So now I'm going to walk you through 3 scenarios of treatment optimization and the decision-making process that we go through in each case. So take a patient who is long-term survivor, who is on a 3-drug multi-tablet regimen, who had prior history of treatment failure. However, they have no resistance to integrases, TDF, or darunavir. In this instance, we can switch them to a fixed dose 3-drug regimen, Cabotegravir, FTC-TAF, or darunavir, Cabotegravir, FTC-TAF. And the data to support this is derived from the GRAVE study, where 99% of patients with pre-existing resistance who were suppressed and who were switched to BF-TAF, who remained suppressed through week 72. And another study to underscore the effectiveness of Biktarvy is this study derived from 1489 and 1490, targeting naive patients and showing that 98% of these patients remained undetectable after 5 years of being on Biktarvy with zero resistance selected through these 5 years. The second scenario is an emerging paradigm where we show that switching patients to a 2-drug regimen worked as well as keeping them on a 3-drug regimen. Again, for this strategy to succeed, we have to choose the right patient population, i.e. these are individuals who should not have had any prior treatment failure, no resistance to any of the component of the 2-drug regimen that we're switching them to, i.e. dolutegravir 3TC, and they should not have active hepatitis B. And the data and the rationale of switching them to a 2-drug regimen is practically to reduce the long-term toxicity by taking away one of the third drug and decreasing long-term renal and bone toxicity and reducing the cost of that therapy and making it more available to other people. The data to support switching patients to a 2-drug regimen is derived from the CELSA study, which showed that 94% of patients who were on a suppressive treatment were switched to a 2-drug regimen and remained suppressed, undetectable, compared to 93% who remained on the 3-drug regimen. And not only this, but this success rate was sustained. And the TANGO study showed that 86% of patients who switched to a 2-drug regimen remained undetectable after 3 years, compared to 82% who remained on the 3-drug regimen. So it's unequivocal. 2-drug regimen seems to be as effective when the right patient is chosen as a 3-drug regimen. And what's also impressive is that none of the patients in the 2-drug regimen who had a confirmed biologic failure had any resistance developed. So that's also very important. And now there is a new emerging trend driven by the long-acting agents, where switching patients to a 2-drug long-acting injectables, Cabotegravir and Rilpivirine, was as good as keeping them on the 3 or 2-drug suppressive regimen. And here again, the conversion success really is driven by the type of patient we choose for this strategy. So to ascertain conversion success, we have to pick people with no prior treatment failure, no resistance to Cabotegravir, Rilpivirine, no active hepatitis B, and they have to be patients who are engaged and reliable. It's very important. And what drives this decision to switch to these long-term injectables, it's usually patients' desire to stop their oral regimen because they are tired of taking pills, they're concerned about HIV disclosure, they are stressed about adherence to daily oral medication, and they feel stigmatized by HIV. And the data to support switching patients to a Q8-week injectables is supported by the Atlas 2M study. And this is a study that enrolled patients who are suppressed in an oral regimen or an injectable regimen and who were randomized to receiving 2 injectables every 8 weeks versus every 4 weeks, and they were followed for 152 weeks. And we learned from the Atlas 2 study is that Cabotegravir, Rilpivirine, long-acting giving every 8 weeks was non-inferior to Q4 weeks with a very high rate of viral suppression. And what we also learned is that only 13 out of 523 patients, i.e. 2.4% of patients, had a converted virologic failures in the Q8-week arms. 11 of these 13 patients had resistance to both Cabotegravir and Rilpivirine. However, 12 of these 13 patients resuppressed on an oral regimen. But again, that underscores the price that the patient may have to pay when treated with a Q8-week long-acting injectable. When you look at the incidence of injection site reactions, you can see that the incidence declines significantly within the first few months after starting the injectables. When you look at the grade 3 events, they are very low in incidence, 4% or less. And the dropout due to injection site reaction was less than 2%. But again, you see that trend where the injection site reaction tend to drop and then plateau after the first year. Now, I'd like to walk you through the injection schedule or the dosing schedule of these long-acting injectables. As you can see, there is an oral lead-in that was required at the beginning, and now it's optional. And what it consists of is administering these pills in that oral form, Rilpivirine and Cabotegravir, for 4 weeks to ascertain that the patient is tolerating them before committing them to the long-acting injectables. And then they come in to start their injections. It's 2 IM injections at separate gluteal sites. And then the first 2 injections are 1 month apart, and then patients goes on to Q2 month injections. And it's very important for the patient to show up within a window of ±7 days from their target date for the injections. If patients opt to skip an injections altogether, they have to be bridged an oral regimen for a month and then brought back in to resume their injection schedules. So if we want to reflect on the pros and cons of long-acting injectables, this is what we come up with. In terms of strength, obviously, this is the first long-acting injectables that is non-inferior to a 3 drug regimen. It's very well tolerated. The weight gain associated with these long-term injectables is acceptable. There's no food restriction. They're not renally excreted. They have a favorable lipid profile. There's few drug-drug interaction, and they definitely help minimize HIV stigma. And the oral lead-in is now optional. The weaknesses of these long-acting injectables is that they have a very long half-life. They tend to last for up to a year. So if someone drops out and drop out of care, there's a real risk of these patients, when the drug level drops below a certain level, for them to select resistance to both drugs. They have to be administered by a licensed healthcare provider. They are given as 2 separate IM injection, and the first dose have to be observed. Injection site reaction continues to be a nuisance. 4% of patients will have severe grade and 1% will drop out. There is a lack of data among women of childbearing age, and the genetic barrier of Cabotegravir is not as high as Dolutegravir. And we had seen, as you noticed, biologic failure with resistance that happens primarily among patients with BMI above 30, patients with archived NNRTI resistance, specifically to Rilpivirine, and patients with clade A and A1 HIV infection. These injectables can pose a burden on practices, logistics wise, in terms of treatment shipment, storage, and dispensation. They require anywhere between 7 to 13 visits a year. And as you know, as you gathered, scheduled treatment interruptions will require back and forth from an oral bridge to injectables. And lastly, global access may be a challenge due to the logistics surrounding the administration of these long-term injectables. Moving on to long-term survivors who are highly treatment experienced and failing with a multi-drug resistant virus. Here, we have to modify their treatments, and we rely heavily on their past treatment history and resistance testing. But the good news is that we have a very effective all-oral regimen that's centered around Fostemsavir to treat this patient with and regain viral suppression. So what is Fostemsavir? Fostemsavir is a prodrug of Temsavir, which is an attachment inhibitor that directly targets the GP120 and binds to the GP120 and prevents the virus from attaching to the CD4 receptor. Hence, it prevents the destruction of CD4 cells. And this drug is very effective in treating multi-drug resistant virus, and the data to support that is derived from the BRIGHT studies. And the BRIGHT studies targeted heavily treatment experienced patients. These are patients who have been on antiretroviral therapy for more than 15 years. They've averaged 5 treatment regimens. 86% of them had AIDS, and 75% had a CD4 count less than 200. And what we learned from the BRIGHT study is that when Fostemsavir was added as a single active agent the first 8 days, there was a 0.8 log decline, which is very significant in viral load. And then at week 96, 60% of patients who were on a Fostemsavir-based regimen had a viral load that was undetectable. And what most striking finding in these studies is the average CD4 gain that topped 205 cells after 96 weeks, which is pretty dramatic, higher than any other multi-drug resistant study. And as we're entering the new era of long-acting therapies, I opted to conclude with this slide. And I wanted to really focus on 3 novel long-acting agents that I feel are very promising. And they are lenacapavir, islatravir, and broadly neutralizing monoclonal antibodies. So lenacapavir is the first in its class. It's a capsid inhibitor. It's a very potent antiviral. It's designated to treat HIV patient who are naive or heavily treatment experienced, and also it can be used for PrEP. It can be administered as a pill once a week or as a sub-Q injection every 6 months. Islatravir is a nucleoside reverse transcriptase translocation inhibitor. It's used for treatment of naive, heavily treated experienced patient, and for PrEP as well. It can be given as a pill once a week, once a month, or as an implantable device once a year. However, this drug development is on hold right now due to a safety signal linking it to a decline in lymphocyte count. And finally, we have broadly neutralizing antibodies that are extremely promising. These are GPS-guided missiles, if you want to think about it this way, that targets CD4 cells that harbor a replication-competent HIV virus. And then they destroy these CD4 cells. That's why they are very attractive for cure-directed studies, because they target the latent reservoirs and they can impact latent reservoirs. Then they're also being used for PrEP strategy, and they are administered as an intravenous infusion every 2 or 4 weeks. And with that, I would like to end with this statement. I believe with all the advancements I shared today and what's coming downstream, I'm confident that we are on the right trajectory to end the HIV epidemic. Thank you.
Well, thank you. And I hope you didn't find it as painful as I did watching it, but.
No, it was very informative. We do, because we have a lot of questions, I'm going to just do your questions now right after. So we have a few questions for you. Can the injections be given at home, or must the injection be given in a medical setting?
Yeah, for the time being, unfortunately, they have to be given in a medical setting or in a pharmacy that, that's designated to really administer these injections. But at least to my knowledge, all injections for the time being are taking place in clinics. And that's one of the limiting factor, quite honestly. And there's no question that we need to be able to be more flexible. And again, ideally, you want patients to be fully independent and able to administer these injections to themselves. But unfortunately, these are intramuscular injections. Again, this is the first generation of long-acting agents, so there is room for improvement. Yeah, this injection has to be given, as I mentioned, in the ventral gluteal muscle, which is the medial gluteal muscle, so it's in the buttocks, and it has to be given by trained personnel, preferably licensed personnel, but anybody who's trained can give it. So there's also a cold chain involved. Rilpivirine LA has to be refrigerated. So again, they're shipped to the clinic. We put them in the fridge. And then usually when the patient shows up, we take them out and let them defrost a little bit, or not defrost, but cool down a little bit, and then administer the injection, because we don't want to take it out before the patient shows up and the patient ends by canceling their appointment, and then we can put it back in the fridge technically, and then you're wasting a dose. So there is some logistics, there's some limiting logistics around it, but yeah, it has to be done in the clinic for now.
Thank you. The next question is, does injectable regimen treatment are done in healthcare clinics, or at some point the patient is able to do well, you just kind of answered that. Can you?
Yeah, it's very, yeah, it's.
Yeah. So the next one is, when you say long-term injectables are not renally excreted, what does that mean?
So what I mean by that is that when these drugs are liberated in the bloodstream and metabolized, their metabolites are not excreted by the kidney. So in other words, the excretion of these drugs is not dependent on kidney function, and they can be administered with people with advanced renal disease without having to adjust the dose or worry about adjusting the dose. So that's a good thing.
All right, so our next question is, can the injectable regimen be provided through a CNN pharmacy as a home delivery like insulin?
Yeah, again, insulin is subcutaneously injected, can be given intranasally as well. This injection, unfortunately, it has to be administered intramuscularly. It has to be, so this is very important. If we miss the muscle and inject this medication in the subcutaneous tissue, in the fat, there's a very real risk of underdosing the patient, because this drug has to really, it must be delivered in the muscle, and then from the muscle, really, it diffuses in the blood over weeks. And that's why we can dose it every 2 months. If you give it in the subcutaneous tissue, that can compromise the bioavailability of the drug, and that can lead to premature failure, biologic failure, and resistance.
Thank you for that. Our next question is the Fostemsavir an injectable?
No, it's a pill. It's an oral pill, 1 pill twice a day, that can be taken with or without food. 600 milligram dose, and seems to be very well tolerated. And again, very promising in the treatment of highly experienced virus patients. Again, because of its property, it seems to kind of like, it almost operates as a CD4 fertilizers. And there's now ongoing efforts to giving Fostemsavir to individuals who have not recovered their CD4 cells. These are chronically infected patients, usually older, and who are suppressed, but for years, their CD4 cell tend to plateau and is not bumping up. Now there's an effort to administer these, adding Fostemsavir to their regimen to see if that can boost their CD4 count. Again, there's no data yet to support this, but what we saw in the BRIGHT study was so encouraging that we're using this drug for that purpose, because the CD4 gain in the BRIGHT study was the highest we've ever seen in any study looking at multi-drug resistant patients who are highly treatment experienced. So that's that.
How many treatments makes one treatment experienced?
Yeah, that was Heshie's question. Hi, Heshie. So it's yes, technically, anytime you switch somebody off their very first regimen, they're technically treatment experienced now. They're no more version. It's not their first regimen. But the nuances here is there are people who are treatment experienced but have not failed before, because they switch because of intolerance to one of the drug, but they switch at a time point where they were fully suppressed when they switched. So that's what, so he's treatment experienced, but with no prior resistance, no prior biologic failure. So that's important to differentiate and discernate between the two. But again, treatment experience is that somebody who's been on one, first the regimen and then they switch, they're now treatment experienced. But treatment experience with resistance, with no resistance, with minimal resistance, or with extensive resistance. So again, there's a whole spectrum.
Okay. Our next question is, do the newer drugs cause lipodystrophy as some of the older drugs?
Excellent question. So as I mentioned, with Cabotegravir and Rilpivirine, when we looked at weight gain that was linked with this combination, it was not as pronounced as we had seen with second generation integrase inhibitor oral, i.e. with Dolutegravir and Bictegravir. So in terms of weight gain, we haven't seen really a signal that's disconcerting so far. Now remember, with lipodystrophy, again, this is a downstream complication of antiretroviral therapy plus other confounding factors, not just antiretroviral therapy, but it takes time to see it. We are not seeing any features, at least over the first 3 years of using these drugs, because these are new drugs, as you can imagine, but we have not seen any signal that can predict that these patients are high risk of developing lipodystrophy downstream. So that's kind of, but again, time will tell, but it's very unlikely they will, the same way as the old generation of first generation protease inhibitor did, Crixivan, Crixbelly, and so forth. So it doesn't seem like we're heading in that direction based on what we have seen so far.
Okay. We're going to take one more question because we have other presenters. The next question is, are the injectables based on weight?
Nope. These are standard injections. So again, the Q4 schedule, and there's a Q4 weeks or Q1 month schedule or Q2 month schedule. The Q4 months, the Q1 month schedule is 2 ml. So they are separate injection, each medication in each product. Or if you're going to give them in the same product, they have to be spread by 2 centimeters, but it's only 2 ml every 4 months, 2 ml every 1 month, or 3 ml every 2 months. and the dose goes from 400, 600 to 600, 900 milligrams. So the dose increases, the volume increases if we want to give it every 2 months versus every 1 month. But it's a standard dose.
Thank you, Dr. Mounzer.
Well, thank you so much for inviting me. And again, I'm happy to address any question via email. So please don't hesitate to do so. And so long and wonderful effort, and absolutely a privilege to be part of it. Take care, everyone.
Thank you. Next up, we have Michelle Troxell presenting.
Thank you. Wow, to follow Dr. Mounzer is pretty cool. That was really good stuff. And all right, so I'm here talking to you as a woman who is living with HIV. I've been living with HIV for 34 years. I am also a nurse. I've been a nurse for 31 years. And one of the things that I know as a nurse is that my #1 priority is to advocate for my clients. And as a person who participates in healthcare, that's also our #1 priority, to advocate for ourselves. Now, I have some key essentials that pretty much only the person who is participating in healthcare can do, because no one can do them for us. And these are to make sure that we're prioritizing our own education. And you're all doing that because you're on this platform. Like, this has been incredible. The more we educate ourselves, the better questions we can ask. And then by participating and educating ourselves, we're also connecting with others, which is really important for our health. I did not always know that this was something that was so important, because I myself had been isolated until, I'm not sure exactly how many years ago, but I was not open about my status. It was extremely difficult working in healthcare, knowing that I had HIV and I wasn't saying anything. At this point in my life, I've determined that that was something important for me to do as part of my advocacy for not only myself, but also for others. But what I realized by isolating myself, by feeling that I didn't need the support, I was kind of robbing myself from that education and that connection that I really didn't know I needed until I found it. Once I found it, I was never giving it up. I am never giving it up. This was like the most incredible growing opportunity of my life. And it just continues, which is really cool. So education is one of the things that, like, we can have our doctors, our providers educating us, but when we reach out and take charge of our own health by educating ourselves, it just goes to a whole new level. My second key is autonomy. And what I'm meaning by this is knowing that no one can make the healthcare decisions for me except me. And I believe that of everyone. Any human has the right to make their own healthcare decisions and have discussions with your providers, be a team with your provider, like be a partner. And if you're someone that may be feeling like that's not a possibility in the relationship that you're having with your provider, if it were me, I would fire that provider, because I believe that everyone deserves access to information in an understandable way. And it's not the same for each person, because we all come from different backgrounds. And when we don't understand something, to ask more questions, sometimes, I have experienced this, it can be seen as being a pain in the butt, to put it nicely. But this is our health, and who is more responsible for our health than ourselves? And sometimes it pays to be a pain in the butt. And trust me, I know that my providers, they love me, but I'm pretty sure that they also probably cringe, because they wonder, what questions is she going to throw at me today? Because I'm not going to know the answer. And Dr. Mounzer, I saved a couple questions. I will save them for later because I knew we were short on time. Autonomy. So if you're finding yourself in a situation where you don't know the correct thing, it's appropriate to ask more questions. If you're still not sure of the correct choice for you, keep asking the questions. Of course, if it's in a crisis situation, you may need to go with your gut instinct, and that's okay as well. You also have the right to change your mind. You may decide you want to do one treatment, and then later you do have the right to change your mind at any moment. So that's one thing that I always wanted to tell my clients, but also my friends, my peers, because dependent upon where we're coming from when we're accessing healthcare, we may not always realize that we have those choices. And I know for me, I sometimes just blindly did what I needed to do in a moment. But again, it's okay when we do that because we get to make those choices. And then the last one is empowerment. And empowerment is one of those words that's a little bit loaded for me because I often hear it thrown around in a way that is not empowering. And what I mean by empowerment is through the education and the autonomy that we have the power. We do have the power when we recognize this and we realize that when we don't ask questions, we're giving away our power. And when we don't stand up for ourselves, again, we're giving away our power. When we don't recognize the choices that we have, and we don't use those choices, we're giving away the power that we hold, that no one else can hold over us because we get to make those choices. And with empowerment, your choices, and then recognizing that our mental health is as important, if not the most important aspect of our health, because our mental health, if it is not cared for in the same way that we care for our physical container, which is our body, it will affect all of our health, the entire being's health. However, how often do we go running when we have a mental health challenge? We often don't, and we kind of like put that on the back burner, and that's not that important. At this stage in my life, I know this is absolutely the most important thing for me, to recognize that the stress that I can put myself under, because that's what I do, that's what we all do, because stress doesn't really come from the outside, it comes from the inside. When we know that that is the most important deciding factor over our genetics, over any medications that we're taking, over any kind of health challenge that we're having, that one will do us in faster than anything else because of the inflammation that it causes, that long-term chronic stress. So I believe that is it for what I have to say. I had a whole bunch of other stuff written on this tiny little index card, but I think I got it.
Thank you, Michelle. That was so inspiring and very important to hear. We're gonna remember you can put questions in the chat. Next up, we have Heshie.
Hey, everybody. So I have to tell you, following Dr. Mounzer and Michelle is a very humbling experience. So I want to say that I was diagnosed in 1989. So I've been living with HIV for about 33, 34 years. When I was diagnosed, I was working at the AIDS library. So my past is, I'm an information geek. I love information. And so when I was diagnosed, I had already helped to establish the AIDS library. So you might say I was like an information, like I just read everything I could get my hands on. And so when I went into the doctor, I had some basis of knowledge to go on. And what I knew was that I wanted a doctor who could prescribe a regimen for me, understanding that if that regimen failed, what my second regimen would be. And when that regimen failed, what my third regimen would be. So I wanted a doctor who was, I don't want to say all-knowing, but I wanted a doctor who was a researcher. So I wanted a doctor who was a researcher. I wanted to be able to communicate with my doctor. I wanted him to know that I was queer. And that was the community that I was about. And I wanted, the doctor to make good, sound decisions, and then knowing that those decisions that are made in the moment are made from the best available pool of information. And what I mean by that is, in my case, I was what's called a long-term non-progressor. So I was diagnosed with HIV in 1989, and I didn't begin my first regimen until 1998. And, and during that period, I went every 6 months and I got my blood work done, and I saw the doctor. And so my regimen, the first regimen I went on was a regimen of D4T and DDI, two drugs that are famously known to cause peripheral neuropathy. And, but they were the only drugs that were available. And so, and they were better alternatives than AZT. And so I went on to D4T and DDI. And then when it was deemed that I needed a third drug, I was prescribed Viracept. And for those of you who know, Viracept has a really funky side effect of diarrhea and gastrointestinal issues. I didn't want that at all. I think I was going away for the summer and I did not want to have to deal with diarrhea. And so my doctor prescribed a drug called hydroxyurea, which was a cancer drug that was developed by Bristol Myers Squibb. And basically, the hydroxyurea was thought to increase the resistance level of D4T and DDI. And so that was what my doctors wanted to make sure, is that I did not develop resistance to the D drugs. And so when I was given the hydroxyurea, it basically hypermetabolized the D drugs and caused the most critical case of peripheral neuropathy. I know that I was out of work for 2 months. I needed a walker, and it was really horrible. And so I want to, not take issue with what Michelle said, but we can make our own decisions. Autonomy is so important. We can make our own decisions, but I think it's really important when we're dealing with issues like HIV and drug resistance and side effects, that we understand in the moment, if possible, what the downside will be. In this case, my doctors prescribed hydroxyurea as the third drug to increase the strength of the D drugs, but it also gave me horrible peripheral neuropathy. It probably was, they made that decision to prescribe that to me based on a bunch of information about the efficacy of hydroxyurea. It just had, the downside. So when you are visiting with your doctor, making decisions, you want to make sure that you have all the information, as much information as you can possibly get when you walk in to see the doctor, which is why it's good to have your questions written down, or bring somebody with you who can be a second pair of eyes and ears is pretty important. And so also understanding that, doctors make prescribing decisions based on the best possible information that they have. But AZT, was the best drug that we had at the time. So all these other drugs are the best possible drugs, and that's why they pass trials and get approved by the FDA. But over the long haul, we might see issues of side effects, resistance, and so it's important to take all that information into consideration when making these decisions. I also want to say that for me, in the years that have, in all the years that I have had HIV, it's been really important for me to become what I call a self-manager of my life. So what I've come to understand is that there are lots of chronic diseases where the symptoms of those chronic diseases are similar to other chronic diseases, so fatigue, nausea, lack of sleep, vivid dreams. You all know the side effects that I'm talking about. And so it's important to just understand about those side effects and then to be able to make decisions based on the information that you have and be able to communicate those decisions or make those decisions in tandem with your doctor. Your doctor is your partner. He's the most important relationship you're going to have around your HIV for as long as you have it. So you want to make sure that your doctors are humble themselves, know to go search for answers to your questions if they don't have the answers. And so just be clear, make decisions about your own care and health. And I'm trying to think, in all the years, again, for me, I had worked at Bristol Myers Squibb. I worked for DuPont first and helped to launch Sestiva, which many of you may know about, although it is old. It's a dinosaur drug. It's a dinosaur drug, but at the time, it was the best drug that had been approved by the FDA. It is a blockbuster drug. And then I went to work for Bristol Myers Squibb, where I helped to launch Rayataz. So for me, understanding, I understood what drug trials were, and I could go to a presentation and hear what Dr. Mounzer presented and be like right on it. Now, not so much. Now I listen to what Dr. Mounzer spoke about, and I tried to see what the slides looked like. And I thought, oh God, I'm so glad there are Dr. Mounsers out there who you could go to. And so that's the other thing, competence, making sure that your provider is competent. For me, I wanted someone who was in research. I wanted somebody who was always on the cutting edge of what was next, what was next, what was next. And I'm very fortunate. I believe that my doctor walks on water, and he's been my doctor since 1998. So we have a really good working relationship as well as being friends. But you want your doctor to be competent. I just know, from the list of doctors that are out there, that there are some doctors that just are not as competent as other doctors. And so when we're looking for a doc, make sure that you talk to other docs, make sure you talk to your friends who are living with HIV. Try to get as much information. Again, information is power. It is the power to make timely decisions with accurate information, because the thing is, HIV is chronic and manageable. And, I often tell people who, will talk about engaging in risky behaviors, and I'll say to them, listen, you want to engage in those risky behaviors, fine. You're a grown-up, you know what the consequences are, but if you're engaging in those risk behaviors, then by all means, get tested periodically. And if you test positive, then get into care, because there's no reason in 2022 why anybody who is living with HIV should die from AIDS or from complications of HIV. So, know who your doctor is, know what you want for yourself, and then go after it, because again, everything points to prospering and living a good life with HIV, but you just need to plug into treatment and care and support. Michelle talked about being isolated and then moving from that space to a space of support and caring and community. And that is the most important thing, because isolation and loneliness can be deadly. It can be deadly. In fact, I saw recently, isolation is the equivalent of 15 cigarettes a day. And so just know that, and know how important it is to have community and have support, have good medical care. Yeah, that's what I want to say. And so now I'm going to turn it back to Nafisah, and let's go from there.
Thank you, Heshie. What an amazing presentation. We don't have any questions right now. I just wanted to thank you and Michelle for doing such an amazing presentation and being transparent and sharing your stories and giving us a wealth of information.
Karam, you're muted.
Yeah,
So sorry. First and foremost, fantastic talks, Michelle and Heshie. Tremendous insight, and I want to thank you, Heshie, for your kind words. Obviously, again, I want to say one thing which drives how I operate. Again, I am a patient as well as a provider too, and I like when my doctor listens, when they think, when they feel, and obviously I like them to remain on the cutting edge because they are taking care of precious lives. So it's very important that they are committed, motivated to really stay on the cutting edge. And obviously I like doctors who are passionate about the work they do and who feel proud and gratified when they truly impact the life of their patients. And at the end, it's a partnership. So I enjoyed doing what I do because I realized from day one that people are living with HIV are different than your average patients because they are truly, they think for themselves, irrespective of what they're struggling with. They are kind of like, they're independent thinkers who taught me a lot over the years. And I think that's extremely important. Listening is probably rule number one to succeed in our profession, and more so when we are taking care of folks with HIV. So again, I want to thank you, and this is a great venue, and I'm happy to come back if you want me back, and answer or address any other issues or any other question. But thank you so much, and stay safe and good luck for all. Thank you.
Thank you so much, Dr. Mounzer.
thank you.